All right, good afternoon, everyone. Just as soon as we said that you could talk, we're asking you to quiet down. Good afternoon, welcome everyone. Thank you so much for being with us today. We are going to get started. On behalf of the Biden and Harris administration, it is my pleasure to welcome you to the Eisenhower Executive Office Building in this beautiful and historic room. Seeing all of your beautiful faces here at the White House for today's AA and NHPI mental health convening. Before I get started, I just want to give a quick thank you to our co-hosts and event partners for today, the White House Initiative on AA and NHPIs, and the White House Domestic Policy Council as well. I want to thank all of our speakers and our panelists who you will hear from today, and most of all, a sincere thank you to all of you, each and every one of you who I know many of you came from far and wide, traveled. You're leaving the work that you are doing, the valuable work that you are doing on the ground, whether it's organizing young people, we have young people here represented today, providing direct services for our community members, or conducting research. We just really appreciate you taking the time to join us for this very important conversation to discuss the mental health needs of our communities. I think your leadership and your presence here are testament to the momentum within our communities to not only have these types of conversations at the highest levels of power, but also to come together to identify concrete steps that we can and must take to address our community's continued mental health needs and our challenges. So to that end, we have a stellar program for you today. We will hear from key leaders from the White House and the administration on the work that we are doing, we have been doing, and continue to do in partnership with the community advocates, including some of you who are here today, to support the mental health and well-being of AA and NHPI communities, particularly since the historic AA and NHPI Mental Health Summit that the White House Initiative hosted last year in 2023. And then most importantly, after that, we will hear from you about the work that you are doing on the ground, your perspectives, your priorities for the work that remains. With that, I just want to do a couple of quick housekeeping items. We encourage you and welcome you to take pictures. While you're inside this meeting space, you can either put away or hide your guest badge. We ask that for photos, those not be in the frame. But of course, once you leave, if you could put those back on. Down the hallway, directly outside of those main doors, you will see bathrooms that you may use at any time. Feel free to get up and use if you need. And then finally, for those who are at the table with us today, you will see that there are push-to-talk table set microphones. The button on the right side that has the little icon of an individual, you just press that. You will know that your microphone is on when it is lit up green, and that is so that the folks who are joining us remotely via Zoom webinar from across the country can also tune into our conversation today. Okay. With that, I'm pleased to introduce our co-host for today's convening and the executive director of the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders, Crystal Ka'ai.
Thank you so much, Kota. Aloha kako. Good afternoon, everyone. As Kota mentioned, my name is Crystal Ka'ai, and I have the honor of serving as the Executive Director of the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders, or what we call WHIAANHPI for short because it's a very long acronym. And I'm also the Executive Director of the President's Advisory Commission on AA and NHPIs. And both of these entities are physically housed within the U.S. Department of Health and Human Services, and we are co-chaired by two members of the President's Cabinet, U.S. Trade Representative Ambassador Katherine Tai, who is one of 4 Asian American women currently serving in the President's Cabinet. And then the other co-chair is HHS Secretary Javier Becerra, who has been a really strong champion for our AA and NHPI communities for a number of years, long predating his time in the administration. Today's event, as Kota mentioned, is being co-hosted by, or we're so pleased rather to be one of the co-hosts of this event in coordination with the White House Office of Public Engagement, the White House Domestic Policy Council, and the U.S. Department of Health and Human Services, in particular with SAMHSA, the Substance Abuse and Mental Health Services Administration. And we have a number of our colleagues here from the administration who you'll be hearing from shortly. But as Kota mentioned, this event is actually a follow-up to an event we convened last July. we hosted an inaugural AA and NHPI Mental Health Summit at the U.S. Department of Health and Human Services. And that was actually a result of a recommendation made by our President's Advisory Commission on AA and NHPIs. Our commissioners felt that there was such a strong need to ensure that we created a space specifically for AA and NHPI communities to address the significant and unfortunately often overlooked challenges that our communities face, and also to ensure that we could talk about the need for culturally and linguistically appropriate services for our communities, as well as the way to address stigma that we know unfortunately still exists for so many AA and NHPIs. We know, unfortunately, that emerging from the pandemic, there are so many mental health challenges. Our communities, not just our communities, but our country has really faced a mental health crisis. And that is something that from the very top, our president, our vice president, as well as our leaders within the U.S. Department of Health and Human Services have really prioritized addressing. And so I'm not gonna go into the substance. We actually have an expert here with our Assistant Secretary for Health, who you'll be hearing from shortly, as well as many of our colleagues from SAMHSA and the Domestic Policy Council. But as Kota mentioned, we also want to use this session to hear from all of you. Our work is so critical in the sense that we have, all of us in the administration have a platform to elevate issues to the highest levels of government. But that work needs to be community-centered. It needs to be informed by those of you on the ground working directly in community who are seeing the day-to-day experiences, the needs of our communities. And so we're so grateful to all of you, many of whom have flown in or drove in from all across the country to be here today, and many who are also tuning in virtually. And so we just want you to know that although this is just the second time we are convening, this will continue to be a priority for our White House initiative to ensure that we are addressing the health needs and mental health needs and behavioral health of our communities. So thank you again for being here today, and I now have the honor and privilege to welcome Assistant Secretary for Health of the U.S. Department of Health and Human Services, Admiral Rachel Levine, to provide remarks. And I'm gonna, if you don't mind, read a really quick bio of hers because she is just such a phenomenal leader. Admiral Levine serves as the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services and the head of the U.S. Public Health Service Commission Corps. She fights every day to improve the health and well-being of all Americans and is working to ensure health equity is front and center to build a stronger foundation for a healthier future, one in which all people and places in our nation can thrive. Admiral Levine's storied career, first as a pediatrician and adolescent medicine specialist in academic medicine, focused on the intersection between mental and physical health, treating children, adolescents, and young adults. Then as Pennsylvania's Physician General and later as Pennsylvania's Secretary of Health, she addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges. So we are so honored to have our Assistant Secretary with us today. Please give Admiral Levine a warm welcome.
Well, thank you so much for that kind introduction, and I'm really honored to be here to join you for this very, very important event. We all recognize that different populations and communities experience numerous health disparities and challenges in accessing care. Racial and ethnic minority populations, including the AA and NHPI community, experience numerous mental health disparities, including higher rates of attempted suicide in adolescents, lower treatment rates for mental health conditions such as depression in adults. Healthy People 2030, which is in my portfolio, defines health equity as the attainment of the highest levels of health for all people. And I firmly believe that we have not truly made progress in health equity unless we have all made progress. Achieving health equity requires valuing everyone equally, but that means making focused and ongoing efforts to end inequalities, eliminate the impacts of contemporary and past injustices, eliminate disparities in health and health care, including mental health and mental health care, and improve the health for everyone. The Biden-Harris administration is committed to transforming our behavioral health system and reducing the rates of suicide across the country. The 988 hotline is a critical part of the Biden-Harris administration's unity agenda. For people who speak other languages, if they call 988, and they can provide translation in more than 240 240 additional languages, including Chinese, Tagalog, and to name a few, many others as well. In addition to dramatically expanding 988, the administration has advanced comprehensive 24/7 crisis care, including mobile crisis support through Medicare and Medicaid, and has led the development of the most robust national strategy for suicide prevention in history. We have shared a federal action plan with more than 200 concrete steps that the government will take over the next 3 years to reduce suicide rates. There are, of course, intersecting social determinants of health, and they can have profound impact on mental health of racial and ethnic minority populations. Living through a natural disaster, experiencing financial hardship, limited access to culturally and linguistically appropriate services, and of course, stigma, surround mental health care and can lead to poor mental health outcomes for any population, but particularly for racial and ethnic minorities. Now, as you can see and was mentioned, I wear the uniform of the United States Public Health Service Commission Corps, and the Surgeon General and I lead the Public Health Service Commission Corps, which includes 5,600 or more dedicated medical and public health professionals that work throughout the country and in other countries as well. And we are first in line to defend our nation against public health threats, including providing behavioral health support. And people look to us whenever there's a public health emergency. So last year, public health service officers deployed to Maui to provide behavioral health services to individuals and families as they returned home after the devastating and horrific wildfires. HHS is committed to working with public health and community-based partners to, quote-unquote, be the source for better mental health by providing racial and ethnic minority populations quality, equitable, and respectful mental health care services. And these services are responsive to diverse cultural health beliefs and practices, preferred languages, economic and environmental circumstances, and health literacy levels. When patients are provided with culturally and linguistically appropriate information, they are better able to create healthier outcomes for themselves, their families, and their communities. So, thank you all for working to improve mental health across our nation's AA and NHPI communities. Your passion, your dedication, and commitment drive positive medical health outcomes and mental health outcomes. So, in summary, despite the heavy toll the challenges of the past 3 years have exacted, including, of course, the acute phase of the COVID-19 pandemic and more, they have reminded us of a fundamental truth, that we truly need each other, that our happiness and our very survival depend upon our connections to one another and to our community. And it is that spirit of our greater community that makes our country great. And it's what we need now more than ever. All Americans deserve mental health care and services that are timely, affordable, accessible, equitable, and high quality. These are our family members, our friends, our neighbors, our students, our co-workers, and more. So we can do better, we must do better, and of course, with all of your help, we will do better. Thank you very much.
Thank you so much, Admiral Levine, for your remarks, for your leadership, and for taking the time out of your busy schedule to be with us today. It is now my pleasure to introduce someone who doesn't really need an introduction. She is the first ever AA and NHPI senior liaison here at the White House. She's been a critical voice for our communities across the administration and inside the building. It is my pleasure to introduce Erica Moitsugu.
Kota, thank you for the generous and unnecessarily generous introduction. But my response to that is, come on now. We're in this for a reason. And let me just start with just a big, sincere, and authentic aloha, y'all. Again, in deference to the biraciality of my children, to honor and name both of their heritages, both from Texas and from Hawaii, our beloved Hawaii. I'm Erica Moitsugu, Deputy Assistant to President Joe Biden and the first ever senior liaison to the Asian American, Native Hawaiian, and Pacific Islander communities, reporting out of the White House Chief of Staff's office. And there I just want to name and honor the Asian American, Native Hawaiian, and Pacific Islander leaders who preceded me, whose shoulders I stand on, who sit on my shoulders. But this is a special position because it's in the White House Chief of Staff's office, because I am not as tiny but more muscular than people think I am, especially on Zoom calls. When I call from the White House Chief of Staff's office across the White House components and the interagency and in community, which is my greatest honor. I want to first express my sincere appreciation to our partners at the White House, the Office of Public Engagement through COTA, and the White House Initiative on Asian American, Native Hawaiians, and Pacific Islander, led by the exquisite Crystal Ka'ai, for bringing us together this afternoon for an update on the Biden-Harris administration's ongoing work to support ANNHPI's mental health since our historic inaugural health summit last year this time. And I should say that it was happenstance that over the course of the past couple of weeks when I've been traveling or doing office visits here in this building and on campus, that last year's summit really has sparked a lot of things, and that even without reference to the fact that we're convening here today with y'all, and by the way, this room is gorgeous. I'm so glad to see so many of y'all, and for those of you who I don't know, I'm so glad to be in this with you and excited to get to know you better and continue this work. But it's been through youth mental health, through gun violence prevention, through gender-based violence. Last year's summit that Crystal and her team put together has really led to focus us, not just on the crisis that Admiral Murthy has talked about openly and explicitly and without apology, but also to be able to curate that for the Asian American, Native Hawaiian, and Pacific Islander communities, which is deeply important. To have my extraordinary colleagues who are much smarter than I am about these things, but to know through lived experience and through our adjacency to all of y'all about how we need to be very tender and tailored and not just templatize it. Admiral Levine, every time I see you, I do have to apologize for fangirling. You are exquisite. Your leadership is extraordinary, and thank you for being here for us as a leader and an ally and an inspiration. She mentioned Healthy People 2020. My father, Kenneth Moritsugu, when he was acting Surgeon General, did Healthy People 2010. So the legacy is strong, and it's a thoroughfare, and I thank you so much. I'm also excited to hear from y'all about how we can develop practical and culturally appropriate strategies to meet continued mental health needs in the ANNHPI communities, plural, during the listening session moderated by our very own White House Initiative Executive Director Crystal Ka'ai. It is my honor of a lifetime to do this work at the White House for ANNHPI communities on behalf of the President and the Vice President, because I'm their representative in our community, which is one of the reasons why this position was created, but I'm also our communities, plural, representative back to the President. So all this travel that I do nationally and internationally feeds into the policymaking that we do. And this makes sure that the ANNHPI are heard and seen and valued to effectively inform our policies. And this is partially, I think, for Crystal and Kota and me, because our heart and home is from the Hill. That's the best way policies are made, is to make sure that we're centering the communities that we mean to impact and to be informed by it. So obviously I don't do this work alone. I do it with Crystal and Kota and their exquisite teams and across the government, including the White House. So I do my work on the entire highway system forged by extraordinary leaders and public servants that allowed me to have this opportunity to be where I am today, to serve you and to listen and learn from you. Because under the Biden-Harris leadership, we've become more visible than ever and are a part of the most diverse administration in the history of our government, for the US history and in the universe, with 14% of appointees identifying as ANNHPI, and 4 Asian Americans serving in President Biden's cabinet. That's unprecedented, and by the way, they're all women. Not to mention the first ever Asian American and female vice president, Madam Vice President Kamala Harris. Representation is important. The reason why I mention this is not just because I'm extremely proud to serve here, but I want to also empower and reveal, and through my revelation, empower us to convey, and again, I'm not smart about this, and so this doesn't dictate what the policy trajectory is, but I have 4 generations of mental health illness in my family. My great-grandmother was suicidal and depressed, but we didn't have words like clinical depression or suicidal ideation. My popo, her daughter, was suicidal for most of her life since she was 20 until she died. My mom, my sister who's deceased, and myself. And I think about 988. I think about this panel here, including, hello, darling, our colleagues who are aware and attentive to this. 988 didn't exist, let alone in language, let alone culturally competent, let alone accessible, let alone publicized. The stigma that my great-grandma felt, the lack of accessibility of services because of stigma for my mom or my sister in dominant culture that was not appropriate and actually created more harms. These are things that we hold and that we carry forward. And so I just want to name that and hope that opens up your hearts with my vulnerability and being able to speak to you about this so that we can learn from you. Representation is also important for our AA and NHPI children. Seeing people who look like them in these positions supports their mental health and development. It's empowering that we have a president and a vice president who value diversity and have placed amazing AA and NHPIs in leadership roles, and not just because we're AA and NHPIs, but because we kind of happen to be the best to serve in that role. So I celebrate with you and the rest of the Biden-Harris administration on the significant progress we've made over the past year. And a great example is the administration's commitment to mental health and the 988, the Suicide and Crisis Lifeline, which I have actually commended to other folks, not only for the folks who are in crisis themselves, but for the people who love and support them and are confused and want to help. It's now in its 2nd year, and we know that 988 is saving lives and helping millions of Americans. So for anyone who's struggling, please reach out through this incredible resource, and if it's not for you, there are other resources, and they actually will provide you with those other resources that might be feeling more accessible and welcome to them. And while we've made great strides, I also encourage you to continue your valuable work, because there's a lot more to do. As a direct result in the spike in anti-Asian hate and violence since the start of the pandemic, coupled with the impacts of COVID-19, the mental health of many in the AA and NHPI communities have suffered. Asian Americans who experience racism feel more stressed by anti-Asian hate than the pandemic. And 1 in 5 Asian American victims of racism experience mental and emotional injury caused by encounters with racial bias and ethnic discrimination, racism, and hate crime. Asian Americans who've experienced racism have heightened symptoms of depression, anxiety, stress, and physical symptoms. And nearly 350 AA and NHPI people die by gun suicide each year. And suicide is the leading cause of death amongst AA and NHPI youth. And among veterans, AA and NHPI individuals have seen the highest increases in rates of suicide. This is data. And this data and what we learn from you is data that we get to use internally to advocate internally about the policy choices and changes that we need to make and the investments. There's nothing we can't accomplish together. As an AA and NHPI community, we know how strong we can be, and I'm encouraged by your work and your spirit. I'm grateful for the opportunity to be here and to share this space with you and to listen and learn from you. So mahalo nui loa for sharing the space with me. So with that, back over to you.
Thank you, Erica, for those very relevant, very personal remarks. Thank you for sharing those. And I just want to thank both Erica and Admiral Levine again for being with us here today. I know you both have very packed schedules, so totally understand if you need to leave us a little early. But thank you so much, both again, for being with us. Okay. I am pleased to now introduce. Do you want to scooch in a seat here? Come on.
Sure,
Yeah, I am pleased to introduce Kylie Patterson, who serves as Deputy Assistant to the President for Racial Justice and Equity with the White House Domestic Policy Council, another critical partner in putting together today's event. Excuse me. Kylie's previous positions in public service cover multiple key positions in both chambers of Congress, as well as Johns Hopkins, the Pew Charitable Trusts, AFL-CIO, and more. But I think the common thread in this career is a clear dedication to diversity, inclusion, and uplifting the voices of communities of color and underserved communities at the highest levels of power. And I'll turn it over to you.
That is right. Thank you. Thank you. And I want to thank everyone on my panel, and I want to, in particular, thank you, Erica, for sharing your personal experience. And I think that's really important to doing this good work that we're doing here. As was mentioned, my name is Kylie Patterson. I'm on the Domestic Policy Council, and I don't know about you, but Domestic Policy Council was not a part of my civics education in high school and middle school. So if you don't mind, I'm going to tell you a bit about what that is. So the Domestic Policy Council is a group of leaders here in the White House who are executing and working on implementing the president's domestic policy agenda. You've heard already from Admiral Levine about the president's unity agenda, just being one of those agendas that we're working on. So I'm going to share a bit around our policies that we've been able to implement that are working to address mental health disparities, especially those that affect AA and NHPI communities. Now, we have to understand why we're doing this, and data truly does drive much of what we do here. And so number one, 18% of AA and NHPI Americans reported experiencing mental illness, but only 25% of those affected received care. In addition, 8% of Asian Americans and 16% of Native Hawaiians and Pacific Islanders report experiencing substance use disorder, with many individuals going without adequate treatment. This is simply unacceptable and must be addressed. Now, what I'd like to also share is that the federal government, while it may seem as though we're working here in this building and you're here in the White House, our actions have a very personal impact on each and every one of you and in all of your communities. And so with that, I am encouraged to share some of our huge policy wins, but know that we have much more to do. And I also know that while we have a number of ideas, we're not the only place of ideas, and so please continue to lift up, share, to comment on notices of proposed rulemaking, and so forth, so we can make sure that your voices are heard. That being said, we have been able to award $700,000 to fund the AA and NHPI Center of Excellence in Hawaii, focused on advancing behavioral health equity. HHS has also funded more than 1,500 community-based mental health organizations serving these communities and awarded more than $1 million to the first ever Native Hawaiian Resource Center on Domestic Violence. That's huge. That's affecting individuals, that's affecting communities, and that's just one example of what we're doing here in the Biden-Harris administration. I also like to draw some of the work that we're doing with DOJ. DOJ has awarded more than $32 million in grants to address the rise in anti-AA and NHPI hate crimes. And education has dedicated $500 million to school-based mental health resources. Department of Labor has developed a workplace stress toolkit to improve employee wellness across different industries. And that's just an example of the wide breadth of opportunities we have working across the federal administration and all of its departments, agencies, and bureaus. Now, this month, I'm happy to share, and I hope I'm not stealing from you, Admiral Levine, I'm not sure if you're going to raise this, but the Department of Health and Human Service published a final rule to extend healthcare benefits to deferred action for childhood arrivals, or DACA recipients, reversing a years-old policy that excluded them from enrolling in qualified health plan through the ACA health insurance marketplace. This will allow and encourage up to 100,000 previously uninsured DACA recipients to receive care. And that's just this month. So I think that's worthy of a little, Yeah, policy makes me want to dance. I know that's odd, but it really does. So the Biden-Harris administration remains committed to improving the health and well-being of the AA and NHPI community, and will continue focused efforts to further access to high-quality behavioral health services with unique attention to the AA and NHPI community and devoted efforts to promoting health and well-being. I do want to end with this, if I may, and I appreciate Erica for leading the way in terms of sharing the personal and how much that drives what we do. And I don't know how Kota got this information on me early, but I, for a long time, up until I was around 13, had a very severe stutter. And I remember going to school and having a teacher who said, your stutter makes your questions last too long, basically. So I'm going to limit you to one question per class. And I was pissed. Oh, I was angry as a little child. I was like, what? You can't tell me that. And I said, I will devote myself to making sure that no one is silenced in the same way. And I think that's what's so great about this administration and about the stories that lead us to this work. And I think when we talk about diversity in this administration, we're talking about that. We're talking about a series of leaders who are working every day, making sure that we're making this world more equitable, more equal, and fair for all of us. So thank you so much for your time. And I look forward to watching the Zoom. I have to run to another meeting, but thank you.
Thank you so much, Kylie. Can we just give up once again for all of our speakers at the opening here? Okay, we are now going to turn it over to our first panel discussion. If I could ask our panelists to come to the front of the table here. This panel is going to provide some updates on the work the administration is doing in partnership with community leaders, researchers, and advocates. And I'm going to go ahead and, Lark, if you also want to come up, I'm just going to introduce Lark very quickly. Lark Huang serves as the Director of the Office of Behavioral Health Equity under the Substance Abuse and Mental Health Services Administration, known as SAMHSA. I will let Lark introduce our panelists, but just briefly, it's been great working with Lark on this panel. She's a licensed clinical psychologist who's worked at the intersection of policy practice and research for nearly 40 years, and a longtime champion for our communities in this space. So Lark, may I kick it over to you?
Okay, are we all set? Kota, thank you very much for the introduction. Thank you for your leadership and commitment to putting this convening together today. And we are certainly all grateful for the opportunity. And I also want to thank the White House leadership, our HHS leadership that just presented to you. And so you're really seeing a set of very talented and passionate people about mental health issues, along with the other issues in their whole portfolio of work. And I think most importantly, I really want to thank all of you who came to attend this gathering today. We were asked to give some names of people to come, and Ventana, you came all the way from California, so Darshan, I'm just so moved, almost moved to tears that you would make that big an effort to come and join us at this convening. And so all of you, whether you're near or far, my fellow colleagues on the panel, we don't get this opportunity very often, and we really have to thank people like Kota, the panel you just heard, and the Biden-Harris administration for raising the issue of mental health to more visibility and raising the issue for AA and HNPI people. So I just want to give applause to all the people who really have done work on this. So as was mentioned, a year ago, we had a mental health summit supported by the White House and with Crystal Kai and her team and leadership at HHS to have the first ever summit for AA and HPI, and that is a lot of words in there. We're going to have to figure another acronym for that. But to really focus on mental health issues in this population. And in many ways, it was a very long overdue summit. It's the first time I've been in government, almost 20 years. It's the first time we ever had a gathering of that sort, really a summit of the diversity of populations, people roles, practitioners, academicians, people with lived experience, federal leadership all come together to really look at what are the critical issues we need to think about in mental health for this population. And it really elevated a focus on the challenges for AANHPIs that often go unnoticed, unrecognized, untreated, and poorly prevented. I worked for a number of years in San Francisco, and I know I have San Francisco colleagues here too. And we had a hard time getting people to come into clinical care. And oftentimes they had to really be severely symptomatic. They were not coming in early, which would have been giving them a better prognosis as well. So the stigma issues, the lack of access to services, lack of access to linguistic services puts major impediments to mental health care for this population. So 5 key themes emerged from that mental health summit we had. And then immediately following the summit, we had another gathering of people around those particular 5 themes in what we called our public-private collaborative groupings to really develop an action plan on each of those key themes. And so we're really pleased that we have the opportunity to give you some updates. And many of you were on, I see many of you around the room and the perimeter were on those work groups and stayed together. And I have to say that was because of people's commitment to it. It wasn't like we could say, we're going to give you a contract to do this. People just stayed involved because it meant something to them and to the leaders that they were and are in their communities. So this panel is going to give you a bit of an update on where we started last year at the summit, on some of those action agendas that were created post-summit, give you some updates on that. And I'm not going to share with you all the data and the figures I had, which drove these particular 5 themes, because you've already heard that from Erica, from Admiral Levine, from Crystal. So they've previewed that. I'm going to just give you now the panelists who were part of those particular work group convenings. And we're going to start first with Annie Saw, who is an associate professor of psychology at DePaul University, and their more extensive bios are in your packets and accessible to people online. So I'm not going to go into their very, very impressive bios. And Annie's going to speak to us about a topic that was already previewed by Erica in terms of the spikes in anti-Asian hate, and what can we do about that as individuals, as family members, as communities? What are the tools that we can use in terms of responding to this hate and sense of discrimination and lack of belonging that's often directed towards our communities? So Annie?
Thank you so much, Lark. I'd like to thank Crystal Ka'ai and others at HHS and the Biden-Harris administration for your steadfast commitment to uplifting and addressing mental health in our communities. Thank you so much, Lark. You have, for so many decades, been such a strong advocate for our communities. The Biden-Harris administration, WHIAANHPI, and other federal, state, and local agencies have made significant strides to address hate, including improving tracking and reporting of bias incidents, translating information about hate crimes into many of our Asian languages, and providing more funding for programming to address hate, among other important actions. And decades of research shows why these measures are so critical. Discrimination and racism, as we all know, take a toll on individual and community well-being and health. Erica kind of shared about the research, but I'll share again that we know hate is linked to increased stress, mental health symptoms, such as depression, anxiety, and PTSD, and also physical health issues, such as cardiovascular and pain conditions. And at the community level, we've all seen it. Hate diminishes our community members' sense of belonging and inclusion. And these harms have persisted across generations, with periods of heightened xenophobia and anti-immigrant sentiment triggering a rise in hate and violence, as we saw during the COVID-19 pandemic. Yet our communities have always been resilient and active in resisting racism. And we partner across different sectors. And as we partner across different sectors, we can begin to chip away at the devastating impacts hate has on our communities. So I'd like to highlight the work of our work group. Some of our work group members are here today that we've been doing to counter anti-Asian hate. Our work group is composed of community members with lived experience, researchers, nonprofit professionals, advocates, and leaders of national and local organizations, along with SAMHSA's Office of Behavioral Health Equity in WHIAANHPI. It came out of last year's WHIAANHPI Mental Health Summit and follow-up SAMHSA hosted Pathways Forward work group meeting. As our work group discussed ways that government and community can partner to counter hate in our communities, we noted that despite persistent violence and hate, there is a lack of consistent response or provision of tools for our communities to address these issues. At the Pathways Forward meeting, we developed an action plan to counter hate against WHIAANHPIs, taking a strengths-based prevention and response public health approach. And since last August, we've been meeting at least monthly. Our primary work has been centered on the development of a toolbox that we are calling, this is a mouthful, the WHIAANHPI Healing, Empowerment, Awareness, and Resilient Toolbox, but it has a beautiful acronym, HEART, that will coordinate and share resources currently available to both prevent hate and support community well-being, belonging, and healing from hate. For this toolbox, we are collecting many types of resources, such as research articles, blogs, fact sheets, flyers, podcasts, videos, and interventions that prevent and support healing from anti-WHIAANHPI hate. And we hope these resources can be beneficial for many different audiences and stakeholders, so we're gathering resources aimed for the general public, but also specific constituencies, such as families, youth, older adults, behavioral health and other providers, employers, and community organizations. As an example of a resource that you might be able to learn more about when you access the toolbox, I'll share a little bit about an intervention supported by a grant from the California Department of Social Services to AAPI Equity Alliance in Los Angeles. It's an intervention that my colleagues Dr. Sherry Wang and Grace Chen and I recently developed. We call our community-based group intervention to promote healing from racism the Healing Our People Through Engagement, or HOPE program. It's undergoing several pilot rounds of testing in 5 Asian American ethnic communities, and it will soon be translated into Khmer, Korean, Chinese, Japanese, and Filipino. I'll share more about this intervention tomorrow at a webinar hosted by SAMHSA. The flyer is in your folder today. But in brief, our program brings together community members who have been impacted by racism. We aim to not just help people cope with the mental health impacts of racism, but begin to engage in radical healing through 6 sessions where they build connection and sense of community, positive ethnic and cultural identity and pride, critical consciousness and action to come together to combat hate, and radical hope for a future of collective wellness and liberation. We expect to share details about this intervention along with many other resources when we launch the toolbox at the end of the summer on NAPIMA's website. So what can you do? You can help us by filling this toolbox of resources to combat anti-Asian and NHNPI hate. We know that there are so many resources out there that you and your organizations and communities have developed, and we'd love to be able to help elevate your work and share it with others who need it. We don't have the link to be able to submit resources here today, but for those who are viewing online and who will get the readout later, we'll provide the link for you to be able to submit after this event. For those who are able to help us advance policy to address not just interpersonal racism, but also structural racism impacting our communities. I'd like to uplift NCAPA's policy recommendations that have come out of their health committee, which consists of many national health organizations serving our communities. They've recommended that SAMHSA continue to invest in and develop partnerships with local advocacy, faith-based, cultural, and behavioral health organizations to help continue to build capacity for us to be able to better link our community members with mental health services. They've also recommended passing the Stop Mental Health Stigma in Our Communities Act to address mental health stigma and disparities and provide funding for outreach and education and require research that disaggregates data on our very diverse communities, and also to build on the successes of the Mental Health Parity and Addiction Equity Act, calling for parity between physical and mental health care services with a special focus on telehealth. And we know that all these resources, whether they're community and grassroots generated or through formal behavioral health organizations, are so critical to address the mental health needs of our very diverse communities. As someone who's outside of government, I've really appreciated having this public-private work group partnership space where we've been able to dream together, to work together, to find ways to tackle problems that no one sector, public or private, can do alone. And we hope that our work group of public and private community members, including those with lived experiences, can be a model of coming together, placing equal value on different sources of knowledge, and recognizing and uplifting Indigenous community resources and strengths so that we can all promote better mental health and well-being for our communities. Thank you very much.
Andy, thank you very much, and we really look forward to the launch of that toolbox at the end of the summer. And as she's inviting people to look at that, go to the site as soon as we get the link up, and NPIMA will be hosting that, to also contribute what you all have been developing that works in your communities too. Okay, we're going to move on to Pada Tsuyamoto. Dr. Tsuyamoto is the Executive Director of the National Asian American Pacific Islander Mental Health Association, NPIMA, and she's going to speak to us about a number of things, but also 988, and you've heard some already mentioned. 988 has been previewed by the previous panel as well. Pada?
Thank you, Lurk. I want to thank the Biden-Harris administration and WHIAANHPI and SAMHSA and OBHE, especially Lark, for inviting me to this convening. A little bit about NPIMA. Since 2001, NPIMA has been a national nonprofit organization working to support the holistic health and well-being of AA and HPI individuals and communities. We are the only community-driven organization with a national mental health focus on AA and HPI communities that integrates an interdisciplinary approach that spans education, training, public health, policy, advocacy, and centers those with lived experience. There's actually a handout in the packet if you want more about NPIMA. Now, this is a very personal topic for me, as I'm a person with lived experience with mental health challenges and a suicide attempt survivor. When I was 16, I tried to take my life. My family has also been deeply impacted by mental health challenges. My father had major depression, my mother had bipolar disorder, and my daughter has bipolar disorder as well. So I've been a caregiver and a person who has faced my own challenges. So I strongly feel that 988, the Suicide and Crisis Lifeline, could be an incredible resource that can save lives. But there are a number of issues that need to be addressed before it can reach its full potential. Like Anne spoke of, I was also part of a work group, and that work group wrote a report called Engaging Asian American, Native, Hawaiian, and Pacific Islander Communities with the 988 Crisis Response Network. And this report was put together by that committee that followed the WHIAANHPI mental health convening last year at this time. As mentioned, in August, SAMHSA and OBHE convened these working groups, the pathways forward. And the 988 Working Committee identified 4 problem statements, followed by goals to speak to each problem statement and specific priority areas and address it, and strategies to address them. I'm going to share one of these problem statements and the subsequent recommendations to highlight not only the scope of the issues that face AANHPI 998 callers, but also to share some thinking on how to remediate and address these issues. So problem statement number 1 says, the 988 system's current framework as a component of the broader crisis and wellness services continuum lacks the essential integration, inclusivity, and sensitivity needed to meet the specific needs of AA and HPI communities. This shortfall underscores the critical necessity for the system to adapt and more precisely align with AA and HPI communities' unique requirements to effectively prevent mental health crises and suicides. So the goal for this problem statement was enhance access to 988 system for underserved communities by delivering trauma-informed services that are culturally and linguistically tailored, and also through comprehensive language support, bias awareness education, and direct linkage to community resources, we aim to significantly increase both the awareness and utilization of the 988 system among these communities. Priority areas were enhanced counselor capacity, culturally linguistically sensitive outreach, diverse representation in decision-making, recruitment and retention of diverse staff, inclusive language strategy, and a national directory for AA and HPI resources. Strategies to address the priority areas were to invest in meaningful collaborations with community-based organizations that reflect the target populations to enhance awareness and information campaigns. In addition, to actively promote, train, and recruit from local AA and HPI communities for 988 call center opportunities to develop a workforce pipeline that is collaborative. Now, there were 3 other problem statements with similar recommendations that I'm not going to be able to share. However, we can see from this one example how nuanced and complex the issue of reaching and providing culturally humble and relevant care to our communities is. I'd like to examine a few more critical issues through a case study. Let me introduce you to Tran. She is a 45-year-old Vietnamese-speaking immigrant who came to the U.S. 4 years ago. She has found it difficult to find work and experience anti-Asian hate during the COVID pandemic. She has been feeling like life isn't worth living and can't seem to get out of bed. She's losing weight and recently found out she didn't get the job for which she applied. She can't stop crying and is hopeless. What stands in Tran's way of getting culturally and linguistically appropriate care from 988? First, Tran has to know 988 exists. AA and HPIs are the least likely to be aware of 988, and yet we are theoretically willing to call. Information about 988 has to reach the AA and HPI communities where we are in relation to the media we consume and the apps we use. There needs to be a 988 awareness campaign to reach AA and HPIs on platforms that AA and HPIs use, like Line, WhatsApp, or WeChat, as well as other in-language media. Tran then has to reach the conclusion that she needs help with her mental health. Despite the shame she might feel because of the stigma in AA and HPI communities, despite the message that AA and HPIs are the model minority and therefore don't have mental health challenges, and despite her worries that law enforcement might be called. In fact, 77% of Black and 72% of Hispanic and 80% of LGBTQI+ Americans say they would be afraid that the police would hurt their loved ones or themselves while responding to a mental health crisis. And 28% of Blacks and 28% of AAPI Americans are significantly less comfortable going to law enforcement officer in a crisis than their white and Hispanic American counterparts. Assuming that Tran overcomes these feelings that she doesn't need or deserve help and actually calls, then she's faced with a new set of barriers. She doesn't speak English or Spanish. So although 988 uses interpreters from the language line solutions, how does Tran let the counselor know she needs a different language if she can't express that in English? In addition, Language Line claims that their interpreters are trained to interpret in crisis situations and given training themselves to help vicarious trauma resulting from calls that are emotionally charged. Yet I know that not all call centers train their counselors on how to use a mental health interpreter. So just because the interpreter is fluent in a language also doesn't mean they're fluent in cultural considerations to make the call truly meet the needs of the AA and HPI callers. We need to at least provide counselors with standardized training on cultural humility and relevance and how to use interpreter services in a crisis call. We also need language-specific greetings and call routing so Tran can efficiently get to a counselor that speaks her language. To make this all possible for Tran, we need research on 988 and the utilization and impact on AA and HPI individuals and communities. And the data for that research must be disaggregated to be meaningful. And we can see that there are many barriers to overcome for TRAN to receive linguistically and culturally 988 crisis care. However, the issue of culturally relevant suicide prevention and mental health care for AA and HPI goes beyond 988 per se. To help guide us, we have the new National Strategy for Suicide Prevention, the Federal Action Plan, which calls specifically for health equity in strategic direction number 4. The goals of this area are embed health equity into all comprehensive suicide prevention activities, implement comprehensive suicide prevention strategies for populations disproportionately affected by suicide, with a focus on historically marginalized communities, persons with suicide-centered lived experience, and youth, and create an equitable and diverse suicide prevention workforce that is equipped and supported to address the needs of the communities they serve. And finally, to improve and expand effective suicide prevention programs for populations disproportionately impacted by suicide across the lifespan through improved data, research, and evaluation. These goals from the National Action Plan are aligned with the recommendations of the 988 Working Group and can guide our way forward toward a more equitable 988 call response system and suicide prevention in general. The advocacy of SAMHSA and OBHE through the establishment of these work groups and the launching of the National Action Plan are steps toward a more equitable system. Yet, suicide is a leading cause of death for AA and HPI young people, as mentioned. And as a community, we are also least likely to get help for diagnosed mental health challenges. So appropriate 988 care could be a gateway to helping, or could be a barrier. It's our choice. Thank you.
Pada, thanks very much for your comments on 988, and the work of the direction and guidelines of that work group has also compelled SAMHSA to really move forward with discussion groups with the 988 office, our office, and the AAPI community. So we'll continue to be in discussion around that. Thank you so much. I'm going to turn now to Dr. Susan Jenkins, who's the Director of the Division of Evidence, Evaluation, and Data Policy at the Office of Assistant Secretary for Planning and Evaluation in the Department of Health and Human Services. And Susan's going to share with you something that has been a long time coming and an issue that advocates in this community have been working on for decades. So Susan?
Thank you very much. As everyone else has said, I'm very honored to be here, very honored to work with this group and work with HHS in general and to work on these issues. So thank you so much for having me. I am going to talk about data and statistics, which are very exciting and we should all be very excited about. And I'm very excited about it, obviously. And there have been a lot of statistics that have been talked about here today. So we know the importance of good data, strong data, valid data, appropriate data, and using those data appropriately. So what I'm going to talk about is what we call SPD 15. That's Statistical Policy Directive 15. The Office of Management and Budget Statistical Policy Directives help to direct the federal statistical systems, which then are followed by state, local, county, private, and other data collectors and data producers to collect and produce strong, valid, reliable, high-quality data. So SPD 15 is Statistical Policy Directive 15, and it provides the standards for maintaining, collecting, presenting federal data on race and ethnicity. And it's designed to ensure the comparability of the data that are collected by federal agencies, and as I mentioned, other groups follow suit and use these same standards. It's to maximize the quality of these data by ensuring a common format, language, and procedures for collecting those data. The initial development of these standards was in 1977. It stemmed in large part from a need to measure things related to civil rights legislation, and many of those needs still exist today. The Statistical Policy Directive was updated once previously in 1997, but we know that since that time, there have been many changes in our understandings of race and ethnicity, the racial and ethnic makeup in the United States, and so in 2024, in March, a revised Statistical Policy Directive was released by the Chief Statistician of the United States. I was very honored to be on the working group that helped to develop the recommendations that went to the Chief Statistician. I was a representative for HHS for that, And maybe because of my enthusiasm or other reasons, I continue to be working on that. I am the HHS representative and the co-chair for the standing committee for the implementation of SPD 15, of these revisions. And so one thing I want to note is that race and ethnicity categories set forth in SPD 15 are socio-political constructs. They are not an attempt to define race and ethnicity biologically or genetically. They're socio-political constructs. And for more information about SPD 15, the revision process, and all of those things, you can go to spd15revision.gov, and there's a lot of information, and over the years there will be much more information. And how the recommendations were developed, there have been attempts to revise SPD 15 at different points in time, but this particular revision was a rigorous process over 18 months with almost 100 listening sessions from the public, a review of more than 20,000 public comments, research and testing of different versions, and significant input from federal staff. And what are the revisions to SPD 15? So the main revisions, and I'll keep it short, the main revisions were collecting race and ethnicity using a single question. Up until this point, there have been two questions, a question about Hispanic or Latino ethnicity with a yes or no response, and then a question with 5 minimum racial categories. There is now one single question, so that brings us to 6 minimum categories, with Hispanic or Latino being a co-equal category to the other race ethnicity categories. In addition, there's an additional new minimum categories that brings us to 7 categories for Middle Eastern and North African individuals. Those individuals were counted under the white racial category previously, but there has been a lot of research, a lot of call for changes in that area. So now there are the 7 categories, with MENA, Middle Eastern and North African, being a co-equal category. With regard to the Asian minimum category and the Native Hawaiian Pacific Islander minimum categories, those remain as they have been, and the definitions remain largely the same. There have been some changes to be more respectful. So for example, with the Native Hawaiian Pacific Islander category, it was previously titled Native Hawaiian and Other Pacific Islanders. And the other, in many cases, is seen as disrespectful and as making one category less than another. So the other has been taken out of that category. And another main change to Statistical Policy Directive 15, which I think is very exciting and which Lark was referring to, is the requirement for detailed data. So in addition to collecting the 7 minimum categories, there's a requirement to collect additional detailed categories. And for both the Asian category and the Native Hawaiian Pacific Islander category, there are 6 subcategories for each of those that represent the largest populations in the United States, and a write-in category if one of those 6 categories does not cover someone's identity. There are requirements also to push for the self-identification and not using proxy or visual identification unless absolutely necessary, but self-identification is important, and a push for more nuance for individuals that indicate that they are multiracial or multi-ethnic. And so making sure that the nuance of those data are reflected, captured, and reported out. So there are a number of important changes to this. And what does this then mean for Asian American, Native Hawaiian, Pacific Islander health? Many people have already talked about it, so I won't go into a lot of detail, but without counting individuals, subpopulations properly and accurately, we don't know who needs what services. We don't know what services work for which populations. We don't know where to allocate resources in order to meet the needs. We don't know how to match services to individuals as appropriately. Those might be language services, other culturally appropriate services, or other needs related to different population needs, different community needs. And so for the sake of time, I will close it there. But part of what this means to you is, as organizations, it's important for you to collect these data accurately, validly, and protect these data. They're an important asset, and we need to protect the data that individuals give us. As individuals, it's important for us to provide these data accurately when we are asked so that we can be counted, so we are not invisible, so that we are able to add to the solution and ultimately have better data for our communities. So I thank you very much, and I turn it back to you, Laura.
Thank you so much, Susan, for capturing that in 10 minutes of what has been decades of work. So thank you, and your leadership on that. Thank you so much. I'm going to turn it over now to Kathleen Wong. Dr. Wong is the project facilitator for the Asian American, Native Hawaiian, and Pacific Islander Behavioral Health Center of Excellence.
Thank you, Lark, and I will try to keep this under 10 minutes. So thank you for the introduction, and thank you, WHIAANHPI's SAMHSA, and as well as the Biden-Harris administration for inviting our center to present here. I am representing the work of our collective, which is part of our center. So we have a very collaborative team. We have members from the State of Hawaii's Department of Health, Papaola Lokahi, which is located in Hawaii, San Jose State University, and my own institution, California State University at East Bay. So as you have heard from other esteemed panelists, there's a lot of great work being done in the area of behavioral health in support of AA and HPI communities, and I'm here to talk to you about the workforce and what we can do in terms of developing the workforce. So our Ohana COE provides, of course, a lot of materials and resources and training to really help our existing existing behavioral health care workforce to support ANAPI communities. And looking at the report and looking at our expertise from the work and the technical assistance requests that we get in, we've compiled some of the major criteria and challenges that we look at when we're trying to develop resources at our Center of Excellence. So I'm going to go over them very quickly. Some of these have been mentioned already. We have a geographic dispersion and density patterns that are distinct to our regions, different regions of the United States, as well as associated Pacific Islands. Some are cities, rural areas, enclaves, non-enclaves, and so our geographic dispersion and density makes it very different depending on locale and where people are located. There's a vast diversity of ethnic and cultural identities rooted in practices and cultural values often shaped by the era and political dynamics of migration or colonization that is specific to the histories of families and communities. This shapes conceptions of wellness, mind-body connection, connection to land, ancestors, history. It even shapes the unit of analysis in behavioral health at the individual level, family, non-kin relations, community, even vast publics. There's a diversity of languages that has been mentioned. Even if some communities may have proficiency in English, sometimes people prefer to talk about personal issues and mental health issues in their own native language. For different segments of our community that we serve, individuals may be bilingual and multilingual, but they may not be biliterate or multiliterate. So I may be able to speak in Cantonese, but I cannot read or write it, and so some of the written materials may not work. There's vast underrepresentation of ANAPI-identified behavioral health professionals, and even among ANAPI professionals, one may not assume that we've had the training to apply our cultural identity and our lived experiences to our professional work. There are persistent patterns of underutilization of behavioral health services by ANAPIs more than any other group. And I just want to highlight some of the key reasons why. There's a lack of culturally informed behavioral health care providers, which sometimes can result in ANAPIs entering the behavioral health care system and quickly exiting after a microaggression or a lack of cultural humility on the part of the provider. There's cultural stigma, of course, as has been mentioned, regarding open discussion about mental health and substance use issues. There's the mono-minority stereotyping that can occur by educators, healthcare professionals, and behavioral healthcare professionals, which prevents even initial assessments or referrals or people serving as gateways for ANAPIs to seek behavioral health care. There's a lack of language, accessibility in practitioners and resources, as has been stated. And then there's historical institutional discrimination across a range of human services with historical distrust of institutions in general in terms of help. And so when we do the work at our center, at the Center of Excellence, there are three things that we try to make sure, there are way more, but I'll concentrate on three. One is to disaggregate by data, which is really important that we talk about that, but to actually follow through and then disaggregate by cultural specificity. It doesn't help if we disaggregate if we don't follow through the logical conclusion, which is we need to carry out this conclusion and disaggregate in terms of understanding community specifically. We need to develop and use culture-specific professional development materials for our client and for our community resources. There's a difference between Pan-Asian political identities and then also ethnic cultural identity, and same for Pacific Islanders and Native Hawaiians. There's no such thing as an Asian American language. There's no such thing as an Asian American culture. There's no such thing as a Pacific Islander language and culture. We may share collectivism, we may share common values, but our specific conceptions of identity, connections to lands, water, and ancestors, the stories that we share, our ancestral lineages, the history of a relationship to historical trauma are distinct to each of our communities. Even our collectivism is expressed differently through the histories of our communities, our migration patterns, and the generation which we belong. And so it's important for behavioral health care providers to understand that so that they can inform and develop trust and really sharpen their cognitive sort of analysis in therapeutic relationships. So again, follow that disaggregation through in your practices. Behavioral health care providers need to be in local learning mode regarding their service area and not be makeup and characteristics of their region and who they serve. Providers can build relationships with local community-based organizations and local social service agencies to learn more about the local community. Even after gathering resources and attending webinars, one needs to learn about your local community to build trust and visibility, and that community, of course, is always changing. Cultural humility as a constant process for behavioral health care providers. This is really important that we just don't do general cultural humility, but cultural humility specific to ANHPIs. What does that mean? Do you see us as one massive group of AAPIs and ANHPIs, or do you disaggregate? Do you think that about NHNPIs as distinct cultural groups, or assume that saying you provide services for APIs, but you have no professional development strategies to learn about NHPIs at all? Do you actively deploy the model minority myth without realizing it and therefore not assess and treat clients? Do you understand indigeneity as a dimension of cultural and racial identity, especially for Native Hawaiians and Pacific Islanders? Do you assume a degree of distance that you have from your client in terms of values and their class and their educational status simply because their accent is different than yours? This might include Hawaiian Pidgin, South Asian British English, Vietnamese, and many other second and third language speakers. We make assumptions as behavioral health care providers. And so this is just an example of the nuances that are really important when we're talking about building capacity. Because for ANHPIs, we know there's a vast underrepresentation. In certain regions of the country, there's hardly anyone there that's from an ANHPI community. And so we need to train through very extensive and detailed training to make sure that we build the capacity of all healthcare providers. The Ohana COE is in its second year of our 5-year grant from SAMHSA, for which we're very grateful. We're grateful to be part of the federal initiative to do this work. In our first year, we provided 2 major community crisis technical supports for 2 major crises that have been mentioned, although there was Typhoon Mawar in Guam in late May 2023, which happened right after we started, and the Lahaina wildfires in August of 2023, which the 1-year anniversary is coming up. Fortunately for our COE, we have an innovative collaborative partnership, as stated, where we've got people on the ground in Hawaii through Papaoa Lokahi, as well as the Department of Health in Hawaii, and relationships with Associated Pacific Islander healthcare centers on the other side of the world. And so we were able to pull together resources. In short, we pulled together resources that used a community model. So when we talk about the unit of analysis, the resources that we pulled together that you can find on our website provide not only behavioral health care support, but also resources for financial support, for things like domestic violence, for negotiating and navigating federal work. Okay, sorry, time's up. I want to mention one more thing. If you go to our website, we have 39 right now, 39 and counting webinars that are located online. They are archived with toolkits. We have had agencies as well as academic programs tell us that they use these. They're free, and so it's a low-cost way of training your staff and having resources. They range a wide variety of topics, and Dr. Sumoto was one of our presenters. And also, we have actively reached out to academic organizations because it's really important that we credential, brand new credential professionals should already have an understanding of the complexities of ANHPIs, and that's another place where we start. Thank you for listening. I want to thank you again for the opportunity to speak, and I'm sorry that I'm not able to share the rest of the presentation that I had prepared. Thank you.
Thank you. Kathy, I've never heard anybody talk so fast. That was very impressive. And our final speaker, and she's going to cut her talk down because we are a little bit over time, so she's going to talk really, really fast, is my colleague at SAMHSA, Dr. Victoria Chow.
Thanks, Lark, and thank you to all the panelists and everyone here today. I appreciate everyone's commitment to this work. So I'm just going to share a little preview of SAMHSA's efforts to advance language justice. For SAMHSA, we're hoping to move beyond language access to language justice. So what does that mean? We see language justice as an environment where individuals can communicate in their preferred language without a dominant language negatively defining their communication and sense of belonging. So what are we doing about that? We've recently developed a public-facing language access plan that will soon be released alongside other HHS agencies' language access plans. This will happen next month in August. I just wanted to share a little bit why this is important. So right now, the Biden-Harris administration has put this issue as a key priority, so we are really trying to capitalize on that. Also, there's a legal basis to provide language justice. Title VI of the Civil Rights Act of 1964 requires federal programs and recipients of federal financial assistance to take reasonable steps to make sure that their programs, services, and activities are accessible to eligible persons with limited English proficiency. So this has existed for quite some time, but we're really trying to make sure that we are doing this work. The third reason why language justice is important now is that the current SAMHSA administration and leadership has put a strong focus on the principle of equity, and this directly aligns with that idea. We know that people with language barriers are more likely to have health disparities, which can result in misdiagnosis and inappropriate treatment. And for people experiencing crises, this can result in life or death situations. So we hope that SAMHSA continues to move forward in this trajectory of reaching towards language justice in order to meet our mission. So what are we doing to do that? We have considered how to make sure that this plan is inclusive of feedback from both the internal staff as well as from community partners and external partners. We've done that by identifying key people and key organizations that we would like to give input to the plan and have opened it up in various ways. And through that process, we have developed a plan. It has gone through multiple rounds of review and clearance. We've made sure we've had perspectives from different disciplines and roles, such as state and local government, nonprofit community-based organizations, behavioral health practitioners, national professional associations, as well as industry leaders in translation and interpretation services as well. We're very excited to release this plan. As I mentioned, it will be next month. It follows a 10-element structure that's closely following the HHS language access plan. And we're excited for this next phase, which will be focusing on the implementation of the work. We will internally develop an implementation plan to operationalize the action steps that we set forth in the public-facing plan. We will certainly reach out to some of our behavioral health partners in the external community, many of you who have expertise, and we look forward to this ongoing work into the future. And I must thank Lark, Tenley, Crystal, Erica, all the leaders here today, Secretary Becerra, our Assistant Secretary at SAMHSA, Dr. Delphin Rittman, for their strong leadership, because without that, we would not be able to be here today. So thank you.
Thank you so much, Victoria. So that concludes our panel. So you have heard something about coping with anti-Asian hate, improving 988, the importance of data disaggregation and policy and program planning, how we can really strengthen our workforce to better serve the communities we're talking about here, and the importance of moving forward on language justice. So I throw out to you, could in fact we think about a national strategy, pulling that all together as opposed to separate thrusts of work? Can we be thinking about it in terms of a national strategy for Asian American, Native Hawaiian, Pacific Islander mental health? Thank you very much, the panelists, for putting so much of your expertise in a small capsule of time. And thank you all. We look forward to discussions after this event ongoing public-private partnerships. And I'm going to turn it back over to Coda. Thank you once again, Coda, for giving us this opportunity.
Well, thank you so much again, Lark, and all the panelists for providing those updates and really sharing what the work that is already going on, and for, as mentioned, putting it into a tiny capsule. We appreciate your flexibility with the timing here. As we get set up for the next portion, so we're gonna do a little bit of a switch around with the musical chairs at the front here. I'm just going to go ahead and get us kicked off on the final portion of the event today, the listening session with all of our community advocates, all of you here, so that we can hear from you. The administration folks who are here to listen to your comments are joining us from the White House Initiative on WHIAANHPIs, SAMHSA, the broader Department of Health and Human Services, and myself with the Office of Public Engagement. As mentioned, we have limited time and we want to make sure that we hear from everybody, so just a gentle reminder to please stick to 3 minutes so that we can hear everybody. I know some folks have some flights to catch right after this concludes. So with that, I'm going to turn it over to the moderator for the listening session, welcoming back the Executive Director of the White House Initiative on WHIAANHPIs, Crystal Ka'ai.
Thank you, Kota, and can we give another round of applause to our esteemed panelists? Thank you all so much. I am incredibly grateful to Lark, Victoria, Tenley, and so many others from the SAMHSA team who have helped to make this work possible. And as you have heard from our panelists, as a result of our historic and our inaugural WHIAANHPI Mental Health Summit last July, we have made sure through SAMHSA's hard work and partnership with community stakeholders in the public and private sectors to ensure that that conversation did not end last July, but that we're continuing that conversation. And that's why with today's event, we're so grateful to all of you, because we do really need to ensure that we, although it's really important to convene, we know that so much of the work happens outside of these convenings, and it is the follow-up that's going to be really key to making sure we are advancing forward. So again, a big thanks to SAMHSA and to our HHS colleagues for their tremendous work over the past year, and to all of you for being here today. So as Kota mentioned, it's really critical, and so many of our White House colleagues mentioned this as well, it's really critical that we hear from you. It is so important that we center our communities and the work that we do so that we can ensure that the policies being put forth by this administration are community-centered and are really addressing the needs, the unique needs and challenges that our diverse communities face. So for this next session, we're going to be hearing from each of you, as Kota mentioned. Each person will have 3 minutes. I know that's not a lot of time, but we're going to actually be having a timekeeper. Swan from our WHIAANHPI team will be making sure everyone stays on track, so please keep an eye out for her. She'll be flashing time cards. But we do want to make sure that everyone in this room has a time to speak, and that is the reason for the time cards. I know it's not a lot of time, but we do want to be respectful of everyone who took the time to fly out here, to come out here for this event, and want to hear from all of you. So we have 2 prompts in particular that we're going to be, and you can respond to either, but I'm just going to be reading these prompts right now. And then again, we will have 3 minutes for each person to respond, and we will be going counterclockwise, so we can start, but let me just read the 2 prompts first. So the first prompt is, what are some of the unique challenges AA and NHPI communities experience with accessing behavioral health services, and what best practices would you like to uplift with our federal government colleagues? So that's the first prompt. So the second prompt is, and we know that our communities are extremely diverse, and they include both Indigenous and immigrant populations with very unique needs, and also with various barriers that they face with regard to language access as well, knowing that about 1/3 of our communities are limited English proficient. So the question or the prompt is, how can we improve resources to better meet the needs of our diverse communities? So you can respond to either prompt. If anybody needs me to reread them, please let me know. I know that we also sent these prompts ahead of time to you all. So we're going to start, start off. Yeah, we'll start off on actually this side. Yes.
Yeah,
we'll
if we can start with Crystal. Thank you.
Okay, just to keep time, I will read straight from the paper. Hello, everyone. My name is Crystal Canare. I'm the Deputy Director of the National Asian American Pacific Islander Mental Health Association, as well as co-chair for the National Council for Asian Pacific Americans Health Committee. As a suicide attempt survivor, as a daughter of a mother who attempted to take her life because the front lines of the pandemic weighed too heavy, as someone who accompanied a community uncle to California because suicide recovery supports were not available in Arkansas, and as someone who has supported families and communities time after time healing following their loved ones' own deaths by suicide, I'm here to say that one death by suicide is one too many, and it takes all of us to turn the tide on suicide. At NAPIMA, we offer free virtual and in-person mental health awareness trainings to ANHPI communities nationwide. The outcome gives me hope. ANHPI communities talking and having courageous conversations around mental health with their families for the first time, ANHPI communities being connected to care, and people holding space for others, holding space for each other. That said, NAPIMA is one of only 6 ANHPI serving grantees who are awarded this grant by SAMHSA, amounting to 0.01% of total mental health awareness training grantees. With ANHPI youth having suicide as their leading cause of death, as mental health utilization rates and ANHPIs being so low, I really call on this administration and our communities to make significant investments in culturally grounded mental health care supports and suicide prevention trainings and programs. As many have shared already and will share in this room, we are taking care of us and really wanting to advance that national strategy altogether. I also want to recognize those not in the room. There's a growing ANHPI mental health care ecosystem of organizations and advocates growing day by day that are answering the call for community care because we need to amidst community trauma, from shootings to COVID to natural disasters and genocide. So to uplift some not in the room today, I honor the Filipino Young Leaders Program, a group of Filipino-American young leaders working with API data and community organizations across the coast of California to study the mental health impact of COVID-19 on their disproportionately frontline workers and their families. I honor the Justice for Young People's Committee, advocating for improved mobile crisis response to ensure a call for help should never end in police brutality. I honor Hawaii Behavioral Health Connection, a funded initiative continuing to offer mental health support to helpers and survivors of the devastating Maui wildfires. I honor Palestinian mental health and wellness, volunteers dedicated to centralizing mental health and wellness resources for Palestinians, Swana folks, and allies in this dire time. And I thank you, Annie, for mentioning this earlier, but I honor my fellow members of NCAPA's Health Committee who developed a set of 2024 policy recommendations around mental health and substance use, and who can provide a roadmap for how we can move this work forward. Not sure what the time is, but our communities know what we need to restore and to feel resourced. So please invest in us, connect and be in relation with us, because we are not going anywhere. We are culturally trusted messengers in our communities, and we are here to work alongside you to stand up all services we need in our communities for our well-being and healing. Thank you.
Hello. Thank you for the opportunity to share my insights. My name is Deborah Kawahara. I am Associate Dean for Academic Affairs at Alliant International University. I'm also the first Asian American woman president-elect of the American Psychological Association. First, I urge the exploration of APA's multicultural guidelines. These guidelines offer a roadmap for psychologists to navigate the complexity of multicultural practice, ultimately enhancing the quality of care for Asian American, Native Hawaiian, and Pacific Islander populations and beyond. It includes acknowledging the unique cultural values, norms, and historical contexts that shape individual lives. It also fosters trust, promote resilience, and advocate for equitable treatment within broader societal systems. APA services supports increased resources for multilingual materials and translators to enhance healthcare access and community engagement. We know that language access and justice is vital for trust building and stigma reduction. Second, discrimination remains a significant issue. According to APA, racial discrimination experiences correlate with behavioral health issues such as depression, anxiety, and PTSD, and physical ailments like diabetes, hypertension, and obesity. Young adults facing frequent discrimination are significantly more likely to develop behavioral health disorders and severe psychological distress. APA Services endorses community-based strategies to combat discrimination, violence, and hate crimes. Lastly, the behavioral health field faces severe workforce shortages, especially for culturally responsive and language responsive providers. Investments in the Minority Fellowship Program funded by SAMHSA are crucial to improving behavioral health outcomes for racial and ethnic populations. MFP celebrates its 50th year this year, and the program has seen 2,200 fellows participate, including 440 Asian Americans. With the strong support of APA Services advocacy, funding has steadily increased for this program. And we ask that these pathway programs continue to be strengthened by increasing the representation and underrepresented cultural groups such as Asian American, Native Hawaiian, and Pacific Islander populations. It is so crucial for practitioners who are from these diverse backgrounds have funding to actually get trained and educated and be able to then reduce the cultural and linguistic barriers that these communities face. Thank you.
Hi, good afternoon. I'm the Chief Executive Officer at Asian Health Services. We are a community health center that provides medical, dental, and behavioral health care services to 50,000 patients in our county with 500 staff, and we are also 50 years old this year. I wanted to just highlight today in particular, because 30% of our patients are adolescents and youth, the challenges of the ANHPI youth, given suicide is a leading cause of death for our youth. Some of the unique challenges for our ANHPI youth include the following, which is also highlighted by a recent study by Dr. Camilla Lewis. Our youth are simultaneously, they carry different identities depending on the space they're in, whether they are the child or they're the family member or in their community or at their school. There's also a misalignment right now between reimbursement vehicles and the capacity and resources. For example, in California, the state has expanded the opportunity to reimburse the provision of dyadic services, and that's a very important service to be able to target family well-being to support childhood mental health development. However, because there is not enough of licensed therapists who speak Asian languages, we are not able to actually tap into this reimbursement mechanism. And it's a common theme that we're all facing. The third challenge is, again, is we heard a lot around aggregating the data for ANHPIs, particularly, for adolescents. We don't see what are sort of the what are the differences because they are masked, and so there is a need to really make sure that that data is disaggregated, especially given the growing number of adolescent ANHPI girls who are at highest risk of suicide. And I did want to say that even my own daughter, in her 4th grade class, there are Asian girls who are talking about suicide even at 9 years old. So I just wanted to say it's critical that the administration consider the following: to increase the visibility of ANHPI identities and their mental health experiences. We also need to ensure that the ANHPI experiences of poor mental health and the burdens they carry in different contexts are validated, that there is educational outreach and media campaigns by and for our youth and their families. We need to improve mental health literacy that is youth-centered and translated to ANHPI languages, because so often there's so many languages, our Asian languages don't have terminology for mental health. We do need to incorporate trainings for schools and mental health providers about our youth and mental health needs. And then just really quickly around workforce. There needs to be investments in programs that support pipelines for bilingual, bicultural licensed therapists. There needs to also be incentives so that they can then work at community-based organizations who primarily serve LEP communities. We also need to increase culturally and linguistically congruent mental health workforce professionals by developing youth peer workforce and non-licensed paraprofessionals. We are currently doing this with our community healing unit that involves non-licensed professionals, and we're seeing great progress. I see my time is up, and so I would encourage, again, some of these recommendations to be considered at all the levels, and really thank you for your time and this opportunity.
Hello, and thank you for your time today. My name is Aisha Azam, and I am the Vice President of the South Asian Public Health Association, a leading organization representing and advocating for the health and well-being of South Asians for the last 25 years. Today, I'd like to share a story about a dear friend of mine, Jabeen, and her journey navigating mental health as a South Asian living in the United States. Jabeen grew up in Virginia. She comes from a loving Pakistani family where cultural values and religion were deeply ingrained. In adulthood, Jabeen began experiencing anxiety and depression. Yet mental health was not a topic openly discussed in her community. There was a pervasive stigma around mental health issues seen as signs of weakness or personal failure. Jabeen felt immense pressure to meet the high expectations set by her family and society, and admitting to struggling seemed out of the question. While Jabeen ultimately sought and received help, creating space for conversation with her family and finding a therapist that met her needs and understood her background took years. Jabeen's story echoes the stories of millions of people living in the United States who struggle to find adequate and culturally appropriate mental health support. There are 5.7 million South Asians residing in the U.S., yet they remain largely underrepresented in public health research, policies, and programs. Research evidence on the mental health of South Asian Americans is limited, especially surrounding older adults. Understanding mental health among South Asians necessitates consideration of intricate cultural, social, and systemic factors. There is an urgent need to build on the sparse research on South Asian mental health status, service utilization, and outcomes. SAFA recommends the following actions for your consideration. 1, mandate data disaggregation. Government health agencies and institutions should be required to collect and report disaggregated data on mental health by ethnicity, culture, language, and other relevant factors within the South Asian community. This can be included in health surveys, electronic health records, and research studies. 2, improve language access services. Ensure that mental health services are accessible in multiple South Asian languages, including providing interpreters, translating educational materials, and offering therapy in the preferred language of the patient. 3, mandate cultural competency training. Train mental health professionals to be culturally competent, understanding religious and cultural differences and backgrounds. And 4, fund and support research. Increase funding for research focused on the mental health needs of South Asian communities. Encourage studies that examine the specific cultural, social, and economic factors affecting mental health in these populations. Provide grants or training to support future therapists from minority communities through state-sponsored programs, and consider the implementation of mental health screenings through insurance carriers to allow for adequate reimbursement rates for all ages. By understanding the specific mental health needs of different subgroups within our community, we can develop targeted interventions that are culturally relevant and effective. My journey at SAFA has shown me the power of community, the importance of culturally competent care, and the necessity of open conversations about mental health. Thank you so much for your time and attention.
Maloilele and aloha. I'm Halaiwalu Wakalahi. I'm the president and CEO of the Council on Social Work Education and a very proud Pacific Islander woman. Thank you for creating this space to gather. It speaks volume to the fact that representation matters and visibility matters. I'd like to acknowledge the indigenous peoples of this land, the Piscataway and the Nacotchtank tribes of this area in particular. So the Council on Social Work Education is uniquely positioned in the social work continuum as the accreditation and education body for all social work programs across the country, from Guam and Hawaii, across the continental U.S. to Puerto Rico and the Virgin Islands. We are over 900 accredited social work education programs in PWIs, HBCUs, TCUs, and HSIs. In terms of social work education, AA and HPI numbers are small but growing. The CSWE 2022-2023 annual program survey reported the following: self-report but important foundational data. BSW enrollment 56,709, 1.8% AA, 0.3% NHPI. We graduated 17,972, 2% AA, 0.4% NHPI. MSW enrollment 83,610, 3% AA, 0.2% NHPI. We graduated 32,801, 3.8% AA, 0.2% NHPI. DSW enrollment, 2,104, 1.8% AA, 0.2% NHPI. We graduated 267, 2% AA, 0 NHPI. PhD enrollment, 1,811, 5.6% AA, 0.1% NHPI. We graduated 238, 5.6% AA, 0.1% NHPI. Social work faculty, 7.8% AA full-time, NHPI 0.2% full-time. I was part of that 0.2% at one time. AA and HPI faculty also created space, including the Asian and Pacific Islander Social Work Educators Association, the Korean American Social Work Educators Association, South Asian Social Work Educators Association, and first time we have an NHPI represented on the Indigenous and Tribal Social Work Educators Association Governing Council. Academic leadership were growing, but still very, very small. Configuration is still lopsided, with AA numbers a little bit better than NH and almost none for PI. As a former dean, I was one of those. Although our numbers are small, this data is a value proposition for all of us. It's kuleana. I certainly hope that we ditto every recommendation that has been made. The data needs to be disaggregated from education to workforce, and investment in education, it is still our best bet. So thank you.
Hi, thank you for having me. My name's June Kim. I'm professor of psychology at the College of New Jersey, and I am also editor of the Asian American Journal of Psychology, which is a peer-reviewed journal that publishes empirical research on psychology by the Asian American Psychological Association and published by the American Psychological Association. And I'm so glad to be here, and I'm feeling really hopeful right now, because one of the things that I've been hearing, one of the themes that I've been hearing is our reliance on data and the belief that I'm getting from our policy leaders that data and science and scientific findings can help find the solutions to our problems. And as editor of Asian American Journal of Psychology that publishes data and science on Asian American mental well-being as well as other issues of psychology, I want to bring light some of the concerns about the availability of data. Again, echoing what everybody else has said as well, but also pointing out the need for greater federal funding. So I realize this is in SAMHSA, but analysis of federal funding for clinical research by the National Institute of Health during 1992 to 2018. Funding for clinical research that focuses on AA and HPI was 0.17% of the total NIH budget. Now you might be like, oh wait, that was, half a century ago, maybe that. So yes, numbers have been improving, so that prior to 2000, we have 0.12, and subsequent to 2000, 0.18. So numbers have been increasing, but I think everybody can agree that that's not enough to help us find the data and help us find evidence-based solutions. This lack of federal support is alarming because without adequate clinical research, it's difficult to develop the science-based interventions that can best help Asian American, Native Hawaiian, Pacific Islander populations. There's much need for research, effects of discrimination on mental health, protective factors that can buffer against negative effects, experiences of war, intergenerational trauma, intergenerational poverty, and all of this research, of course, needs to have disaggregated data so that we can have specific targets for our different communities. I I think I am, oh, okay, I do have time. And I also wanted to point out the intersections of socioeconomic status, religion, and other identities that we all bring to the table that also need to have greater federal funding for research, because again, without the actual data, it's hard to figure out what those interventions are that we all clearly want to help with. Thank you so much.
Creating space for people is the most powerful and generous thing you can do. These words, spoken by our founder, Philip Lim, at the inaugural Creating Space event last July during BIPOC Mental Health Awareness Month, encapsulate our mission. With around 400 attendees, from mothers, young professionals, to teenagers at New York City's prestigious Barclays Center, the event marked a significant moment in our journey to transform mental health support within the WHIAANHPI community. Hi, my name is Rebecca Ma. I'm one of the co-founders of the Creating Space community. Today I want to share a little bit of the work that we've accomplished in the WHIAANHPI mental health space since our inception 12 months ago. Our mission at Creating Space is to reimagine mental health sustenance in the WHIAANHPI community by fostering and destigmatizing intergenerational and intersectional mental health conversations. We create space. We offer free community events featuring expert panel discussions, interactive audience sessions, and experiential workshops for WHIAANHPI individuals to begin their mental health journeys. We create change. We work with thought leaders and community partners to fund individuals and organizations championing mental health in our communities. You can think of us as a new type of community center, a physical and virtual space where those who feel like outsiders can find belonging. We provide a safe, dignified, and supportive environment for young and old, friends and strangers to listen to and share their stories. Since last July, we have hosted 3 large-scale, free guided community sessions on both US coasts. We've also partnered with journalist Lisa Ling for an event in an LA film production studio, to collaborating with USC's Dean of Religious Studies for an event bringing together 250 students and community members. We've also engaged participants in curated healing practices such as yoga, journaling, breathwork, and even dancing, and achieved a 95% return rate based on post-event surveys, with attendees eager to bring friends and family back to future events. One of the key challenges is financial accessibility, and all Creating Space events are made possible by generous donations, allowing us to keep them free for the community. As calls to action, it'll be amazing to find more funding to provide more free community events, deepen investments in clinical research in the mental health space, but most importantly, inviting you all to collaborate with us as we organize more events in different cities, such as San Francisco this fall and Hawaii next year, and more to come, finding new ways to bridge communities and bring people together to talk about mental health. There's strength through authenticity, and together we can make a difference. Thank you.
Is it okay if we combine times?
Awesome, okay. Hello everyone, my name is Soha Mahapatra. I'm from Maryland and I'm a rising junior in high school.
Hi everyone, I'm Ethan Su. I'm from San Francisco and I'm going into my sophomore year of high school. And we're here with some of our leadership team. So we got Reed Chan, Camille Chu, and Taryn Huang. And we are all proud members of the Asian American community, and we represent AAPI Youth Rising. AAPI Youth Rising, or AYR, is a youth-led organization founded in 2020 in response to the rise in Asian hate during the pandemic. Today, AYR has more than 150 chapters across 35 states dedicated to uniting against hate and creating positive change in our communities. We are here to share the unique perspective of AAPI youth regarding mental health. To start off, we would like to share some quotes from our youth members about mental health.
The model minority stereotype has had a huge impact on myself and many others. If we don't conform to this stereotype, we don't feel worthy of being Asian. These expectations of us were set for imaginary superhumans.
With all the negative news about China's election interference and spying tactics, I'm conflicted on how I should feel about my background and whether people see me as someone from there.
My perspectives, experiences, and entire life have been shaped by the stereotypes of my classmates. These stereotypes are based just off of what I look like, and yet I'm still not considered Asian enough because I don't look like an East Asian individual, which is the only part of Asia that my classmates know of.
My classmates make fun of Asians in class and ask if it bothers me. I don't say anything because I don't want to be targeted, but when I tell my parents, they don't believe in mental health. You'll notice common themes from these quotes: anxiety, social pressure, and stigma. These affect millions of youth across our nation. They manifest, however, in a unique way for Asian American youth. The Asian model minority myth means we have to score 110% to succeed. We have to work harder than everyone. We are expected to be quiet, submissive, accepting, and invisible. When we can't meet these expectations, we feel stress, unworthiness, and anxiety. These, by the way, are feelings we're not supposed to feel at all. These are excuses. In Asian cultures, mental illness is taboo and a sign of weakness. We are expected to power through. Furthermore, this myth antagonizes our minority friends by creating artificial labels for good and bad minority groups. This makes us, as Asian American youth, feel isolated and alone. It's really difficult to be first seen as different, second as foreign, and third as Asian. Our identities beyond those don't really matter. We are constantly othered. We feel the need to sacrifice our Asian identities to fit in. This conflict is stressful. It leads to more loneliness and anxiety. When we try to celebrate our heritage, we are hesitant because of the politicization of diversity, activism, and awareness. Social media also exponentially amplifies stigma and pressure to conform.
AYR is proud to say that we've been a part of a variety of initiatives to champion the mental health of AAPI youth. For example, AYR is a partner of the Act to Change organization, and with them, we've worked to raise awareness on bullying prevention and fostering communities with tolerance, safety, and belonging for AAPI youth. We've also worked with the Bullying Prevention and Mental Health Promotion Lab at the University of Maryland to publish the first ever Asian American Bullying Survey report. We've also worked with political leaders to support various pieces of legislation relevant to this issue. For example, AYR is a supporter of the Stop Mental Health Stigma in Our Communities Act, introduced by Senator Mazie Hirono, and we've supported Representative Judy Chu's resolution to make May 10th, 2024 National WHIAANHPI Mental Health Day.
However, there's still a lot to be done. We believe that the key to improving mental health of the AAPI community is education. There must be increased access to education that features factual, objective information about the AAPI community and their contributions to America. The best way to defeat stereotypes that damage the mental health of community members is to provide access to factual information.
Speaking of access, the second action that we need is ensuring equity of mental health resources to AAPI youth. A quote from one of our young members is, "I don't know where to turn for help." This needs to change to ensure that people know what resources are available to them. Unfortunately, the stigma behind mental health means that a lot of people don't access the resources that are available to them. As a community, we must actively work together to destigmatize mental health. This means fostering an environment where people are comfortable seeking help, and we recognize that mental well-being is just as important as its physical counterpart. As youth, we have our own unique perspectives and experiences, but we also believe in the power of our community to overcome adversity, to create a future where AAPI individuals and their mental health are a priority, and all AAPI individuals
can thrive because they have access to the resources they need to maintain their mental health.
Yeah, we just want to thank you for the opportunity to share.
Thank you very much. I appreciate it. I'm Sudarshan. I'm from Columbus, Ohio. I'm a former refugee from Bhutan. I've spent around 17 years in a refugee camp, moved to the United States, and I started working for a community. It's been 15 years working for a community, and my passion is in mental health because I'm a survivor and a person with a lived experience. And so much has been talked about data here, and I don't want to repeat the same thing that is, I think, very clear. Very briefly, I'm a mental health therapist and a practice nurse, and also a community leader and advocate. And from that perspective, without going too much into the data that I have, I'm honestly skipping that portion because my colleague really eloquently shared that one and need for the funding and whatnot. And so what I have seen in my sort of 15 years in the United States working as an advocate and someone with mental health, and had opportunity to work with SAMHSA and HSS at a different time and different responsibility, is that in the refugee community especially, the mental health is not very much understood. And the distinction that I wanted to make with the immigrants and refugees is refugees come towards the end of their the life of survival or struggle. And then when they come here, they are often overlooked and then mixed into the larger immigrant community, and they're expected that they are, again, modal minorities coming from Asia or coming from other places, and that overlooks their real condition. Now, I am into research. I do research beside my community work, and what we have seen, and that need to be improved, beside the funding my colleagues share about, is the fact that AAPI community need to develop their own interventions. And what is happening here in the last 15 years that I have observed is we are constantly referring people to go seek help in the mainstream community. And over the 5 years I did myself, and it didn't produce any result at all. Because one simple example is 3 minutes, and I already got a time warning. The point is that the Western interventions are fantastic, they do well, but they are not developed for the population that we are working. And their primary one distinction in this short span of time that I wanted to make is Western interventions are developed from an individualistic culture where you target one person, try to heal that person because you believe in an individual. But where I am talking from, or where people are coming from, is in a collective culture. In a collective culture, you don't want to apply something that's developed into the individualistic culture. However, what happens on the ground is the therapists, the providers, the mainstream mental health providers push you out saying this is a scientific method, this is well proven, and you have to, that's something wrong with your community. That narrative, it took 5 years for me to really digest the narrative and be able to understand. I work with fellow friends who are in research, who are in teaching and whatnot. And so we have found out that if you came up with your own interventions, if you came up with your own screening tools, you have a better chances of elevating the mental illness in your community. I have 1 minute. And so I strongly insist 2 things. My recommendation would be funding need to go to this community organization directly. If funding are going to the local agencies and local government, what happens is that stakeholders, they get the big lion's share of the money. And then a drop is sent to this community-based organization. And so second thing what we have to do is we have to empower communities that they have some sort of credibility to provide mental health services. You know, I am a licensed social worker, but given my own status as a refugee and whatnot in the community, it's very difficult to make my point that we need a separate intervention. Now, in 1 second, what I wanted to say is, even in the last 2 years, we were able to develop interventions and we have tested out those interventions. We have no money to implement those. And so it's where I'm coming here to ask you for your help. We are able to solve the problem that we have seen in our community, but our hands are tied by the system. And if you enable us to open our arms, we'll be able to address the issue that we have in our community. Thank you.
Thank you. Talofa ma lo le soifua manuia ma le langia ma. Whaaftai wa tātou wheloa ili neila wile ili le alofa ma le anga leo le atua. Whaaftai atu le pa ia wa awhia. Ai mai se fo io i la tau wa mwhai ona mai mō mai ili nei whono. Whaaftai ma lo ua wanoa. My sacred acknowledgement to the land, to the heavens, and those of us who are in this room. Blessings to your health and your life. I am Natalie Tualemoso Asun. I am the Director of Community Engagement and Government Relations at RAMS, the Richmond Area Multi-Services, which is a nonprofit mental health organization in the San Francisco Bay Area, and I'll defer the rest to Angela after me. I am here on behalf of the Regional Pacific Islander Task Force. I am one of the 4 co-founders and of the Regional Pacific Islander Task Force and the current co-chair. And the purpose of founding this organization or this grassroots effort in the Bay Area is to increase the visibility of Pacific Islander needs, assets, and strengths. We are community focused. We are an advocacy power, elevating Pacific Islander health and social needs along with assets. We are also in this role to advance data equity efforts and be the go-to to liaise between systems and our Pacific Islander in the Bay Area. We are in partnership with 6 counties and their health departments in the Bay Area: Alameda County, Contra Costa, San Francisco, San Mateo, and Santa Clara. Today, we are here. Our collective goal today is to reverse mental health disparities. 1, data disaggregation is a mental health determinant. AAPI aggregation of data serves no one. It creates policies and programs that are misinformed and misguided. Data aggregation results in an erasure, oversight of smaller count groups within the Pacific Islander and AA populations. We ask your help in the full implementation of the OMB 15 and also its enforcement. 2, language access. The Regional Pacific Islander Task Force is a proud co-sponsor of the SB 1078, a language access bill in California to improve language and communication access to state government health services and programs for 6.4 million California who have limited English proficiency. 3, invest substantially in community-based organizations serving Pacific Islanders and all of our AAPI groups. That too is a mental health and health determinant. Building their infrastructure, organizational and personnel capacity so they are able to increase the access to our community who seek the first place they go to for mental health services or any service is a community organization whose staff speak and understand their culture and languages. 4, take culture is a mental health and health determinant. Take culturally specific practices, values, and protocols, unpack and apply them to current health and mental health conditions. Prevention and treatment are both necessary in achieving mental health equity. RAMS in the last 10 years, I've been in a position to steward and direct prevention and early intervention work for our Southeast Asian community, our Filipino community, and also Pacific Islander community in San Francisco and also in Alameda County. So we ask your help of all of these. Many of our programs are based on values that are and strengths of our community and that are most familiar with our community and also have a very high likelihood of being accepted by our community because these are values that appeal to their heart and soul. And with that, I thank you for my time.
Good afternoon. My name is Angela Tang, and I'm from RAMS. As Natalie mentioned, we're a nonprofit mental health agency in San Francisco Bay Area. We serve across the entire lifespan in a variety of settings, from preschools to high schools, clinics, and vocational services. In considering some of the unique challenges that our communities, our WHIAANHPI communities face when accessing behavioral health services, we know there are multiple compounding barriers, from immense stigma, which prevents many from seeking help, to behavioral health workforce shortages. Some strategies that I would like to lift up today are, first, concerted, continued effort for supporting the full continuum of services, from prevention and early intervention to ongoing mental health support and crisis response. We know we are in a time of heightened mental health needs, and we must continue to respond to those needs, and also cannot leave behind the prevention and early intervention work that we know is part of the continuum of care. We know that there are effective methods out there like curriculum and psychoeducational groups on mental health topics. The second is supporting integrated cultural healing practices like acupuncture, acupressure, food and nutrition, expressive arts. We know that our communities may seek these practices alongside or even mental health clinical support. The third is workforce development. We know that we have a shortage of culturally responsive practitioners, and we need to continue to support the pipeline. Many existing providers are facing burnout from increased community needs, and these same providers are facing their own stressors. We know that there are effective retention strategies such as ongoing mentorship, training, financial support to alleviate increasing costs of living and student loan repayments. To increasing providers, strategies can be early exposure to mental health careers, to high school students, tuition scholarships, and promoting various training avenues such as certificate programs and clinician pathways. Fourth but not least is increasing the support of collaborations and partnerships between mental health organizations and other settings such as schools, primary care, faith-based organizations, and neighborhood centers. We know that our communities are already in these settings, and we have an opportunity to amplify mental health outreach through these connections. These partnerships can take the form of mental health providers being on-site at centers for training and workshops for staff and families. And there also needs to be support for building out the actual partnership. For many entities to come together to meaningfully understand each other's needs, do trial and error, and try out different models. Even in situations where there are two groups that are very motivated to work together, it's oftentimes on top of the high levels of direct service work that we're already doing. So really having the carved out capacity building to be able to really foster and build these partnerships. Having these dedicated resources would really amplify the existing mental health services that are already out there. Thank you for your time, and I also want to echo all the other strategies that have already been set forth. Thank you.
大家好，我叫陳健。大家好，我叫陳健。So my name is Lily Chen. It's a different name than Jen Chen, but I am the executive director for United Chinese American WAVE, stands for Wellness, Advocacy, Voices, Education, and Support. First of all, I want to thank you, Ethan and Soha, for your incredible, powerful voice. As a parent of 5 children, I wish I knew what you were experiencing. I think the mental health crisis, youth crisis, is it takes a whole society effort. While we face so many structural challenges, many of you have experienced, and parents also play a critical role. I wish I knew what I know now about what my children experience, and also the mental health knowledge I didn't have, even as a nurse educator, because I immigrated from China. I didn't have a psychiatric nursing education in China. And so that's our youth mental health collaborative focusing on parent education. Of course, we love to hang out with you guys too, and we just have 2 focus group this weekend. One consisted of 13 Korean refugee youth, And the other focus group is about 4 or 5 youth. So the focus group is one of the examples of advocacy we're doing. We're actively serving the community as a community-based organization while building our own research capacity. I 100% agree with you, Sandasha, about investing in the community-based organizations on their research capacity. Nothing about us without us. Because we are the one closest to the problem. Therefore, we know the solution, the best fit into our community, especially in a cultural linguistic minority population. I have 1 minute left. And I will give you another example how we build our data. We're doing the mental health first aid training. Thank you, SAMHSA, for sponsoring that. We build our evaluation to evaluate the effectiveness of the culturally adapted Chinese curriculum. For example, give you a data point. We have 1,013 people attempted to register for our training last year. Only 259 were trained. 33% of them stopped registration when they were asked for names because of the stigma. That's our interpretation. And also, we find out another data point about our mental health first aid training is about 13% people would like to have help, couldn't get help. 19% of the people, the help wasn't right for them or couldn't find. So these, I think the solution, not only we need to invest in community-based organizations, we need investment for the capacity to build our own research capacity while collaborating with the researchers. Thank you so much for your time, and thank you again.
Good afternoon. Good afternoon and Jumrib Sur. My name is Fatana Peng. I'm the Executive Director of the Cambodian Family Community Center based in Orange County, California. It is my great honor today to be invited here, and thank you so much to the White House for having all of us here today. The Cambodian family have served the immigrant refugee communities in Orange County, California for 44 years. Next year is going to be our 45th anniversary, and we are a nonprofit organization that was founded in 1980 by a group of Cambodian refugees who escaped the Cambodian genocide. And there are so many challenges. I listed over 20 challenges, but due to time, I listed the most 3 major challenges that the community we serve have faced. One is the lack of mental health therapists who speak in language, especially in the Cambodian language. That points to the lack of bilingual bicultural workforce. In all Orange County, California, there is only 1 medical doctor and 2 mental health therapists who speak Khmer that serve almost 10,000 Cambodians in Orange County. And if a community member needs a mental health services, they have to navigate through complex mental health system. Whether you are moderate, mild, moderate versus severe, you have to go through those navigating, and also have to navigate through looking for a provider who speaks the language. And then often take multiple buses to a location where a provider that provide in-language support. And therefore, we need to increase the pipeline of workforce and the capacity of ethnic serving community-based organizations who are ready to provide clinical mental health services. Also, I would like to uplift the work of the Office of Behavioral Health Equity at SAMHSA under the leadership of Dr. La Quang for what we call Elevate Community-Based Organization to build the capacity to increase the visibility and include CBO as a funded partner in all SAMHSA and other federal requests for proposal. Second is the lack of the awareness about mental health resources due to the lack of funding for targeted in-language outreach and education. Orange County, California has many mental health programs and services. I'm sure you all know too, maybe in your county, but over 75% of the community we serve were not aware of those resources due to the language barrier and also the lack of targeted outreach and education. We need to uplift the value of our community practices, especially cultural practices, to increase better mental health outcome by incorporating that cultural practices into our mental health outreach and education. For example, in California, we have what we call community-defined evidence practices, supported by the California Department of Public Health through the California Reducing Disparity Project. Go and find it out for that one. Last but not least is the ending of the federal funding for addressing the social determinants of mental health and healthcare services, including civic and community engagement. Our county received funding from the CDC to address social determinants of mental health that came to an end in June 2024. CDC provided the funding through what we call Equity in Orange County Initiative developed by the Orange County Healthcare Agency. That funding that came about because of the COVID-19, and that funding has been very helpful to build the capacity and civic and community engagement of the resident and intentional partnership. For example, that funding is a model for our community because it has developed resident civic engagement and local capacity to influence local decision-making processes. As we know, at the end of the day, it is a community who live in that community, who work in that community, has been impacted, and we need to build the capacity of that community to make changes. And by doing that, we want to have this kind of funding from the federal level to allow the CBO like us to address, to build the community capacity in addressing the impact of COVID-19 and also the impact of mental health in our community through building their civic engagement capacity, local engagement capacity. And this is one of the very few kind of funding from the federal government that allows to build this kind of a collective partnership and also intentional partnership with the residents themselves. Not just like, this is what we have for you, but we want to hear from them what we need to do together with the residents who live there, breathe there, work there, to tell us what we need to do to influence decision making at the local level. At the end of the day, we know the funding comes from the federal, but also funding at the local level that we need to make impact and changes, and that's what we are planning to do. And thank you so much for the time.
Good afternoon. My name is Eileen Pan. Thank you so much for provide this great opportunity, to hear the voice of our community. I'm so grateful. So I'm the founder and executive director of the Mental Health Association for Chinese Communities. So I'm so happy to be here to learn from you guys because I learned a lot. Thank you. So talk about the, I found the organization is the peer-run community-based organization. So this organization, I think, is why we found this is because the very big is a language asset. We want to help the people who had the language barrier. So actually our 800 yesterday just received a call. The woman who diagnosed the depression, she quit the treatment. She quit the treatment because she don't understand what the psychologist, psychiatrist talk about. So that's made me to think about another things about the Half Moon Bay, the shooting, right? The shooting before the tragedy, Mr. Chow, because I already contact with him, the government had a serious mental health condition, but he did not know how to take the medication, then to not know enough English. I was shocked when I heard this from him. Because this one, his condition was not well controlled in the past years before the tragedy. It doesn't excuse his actions, but rather shows the deep need for the prevention and early intervention to help avoid these things, right? So our 819, we provide every day for 12 hours, service, free service. But just like Dr. You said, at least the grant, we only received the $6,000 in the past 10 years. So, and this grant, the funding is from the California Warmline. So, yeah, we try our best to service community, but we need a lot of support. Yeah, thank you. I know the time is up. Thank you so much.
So you can hear me. Thank you, and we're almost done. I'm the last one. I'm Kate Lu, Huixing Lu. I am the clinic director for CCACC Health Center from the Chinese Culture and Community Service Center, 23 miles up north from here. So we are local, and we are grassroots community for 40-some years. And the health center started in 2003, and for a long time, we only focus on health because there's no mental health in the Asian community, nothing, no problem at all. Until I joined in 2011, I'm a clinical social worker, and also for a long time, I don't know how to do mental health. It's just hard. People know that I have mental health background, and people just avoid eye contact with me and just fearful that to talk about mental health. But what we were able to have actually some community psychiatrists, community doctors, they actually started this Mental Health 360 program in 2015. And so the doctors identify anxiety, mental health, depression in their practice, and they realize that use up a lot of the medical resource in treating mental health problems. So the doctor said, let's do it right. Let's just form a mental health program. So we did since 2016, and we actually serve direct service. We have psychiatric visit service, and we have mental health counseling visit. But the majority of things that we do is actually community mental health, which cannot be billed, but the impact is huge. So one of the programs we do is called PEARL, Program to Encourage Active and Reward Life. So this started, it's an evidence-based program, and it's started from, we have trained counselor intern and social work intern. I'm a field instructor, so I have students from the local university, and I train them, and they can just call the senior that we identify they are depressed and socially isolated. So we just send them out to call the senior, so they get connection, and we identify goal to improve their life. This is one actually huge thing that has struck me. This morning, I find out that one of the clients served in Pearl program actually fall in his apartment and was dead for a few days, and nobody knows. So it really hit me hard because we're all from the AAPI community. Collectivism, it's one of the things that in our society, when we move to this country, that part is largely lost in the immigrant community. So just one of the little things that I want to share here. We definitely need a lot of funding support. We touch a lot of life, but it's so hard to figure out funding support from the federal level, the state level, and the ground level. So we have a lot of resource to leverage with the resource. Yes, and my time's up. And if anyone wants suggestion for a restaurant, nice place to see, come to me. Thank you.
Nira, I see you've joined us to speak. Please turn on your microphone. You can be our last speaker. Thank you.
Namaste. I'm Dr. Neeta Singh. I am the child of immigrants born the year that they came from India. And I witnessed how hard it was to navigate the complex system of care to access services for wellness. And that started my journey in this field. I've worked over 30 years in nonprofit community health, serving and advocating for health parity for immigrants, refugees, asylees, and asylum seekers. It's an honor to be here at the second convening and to be a part of the 988 work group as well. For almost the last decade, I am the Director of Behavioral Health at ACI, Asian Americans for Community Involvement. We're also celebrating our 50th year. We were established in 1973 to really address the unmet needs of Southeast refugees. And today we serve the diverse community of Santa Clara County with cultural humility, sensitivity, respect, and advocacy for serving marginalized and underserved ethnic communities. Our mission is to strengthen the resilience, hope, and hope of our diverse community members by improving their health and wellness through our array of services. So we're a federally qualified health center with primary care and dental. We have wellness prevention services for our youth and adults. We have a domestic violence and human trafficking program and our Asian women's home shelter. And I oversee our array of services across the lifespan for behavioral health, including our Center for Survivors of Torture, which serves refugees, asylees, and asylum seekers from all over the world. What I really wanted to make sure that I had the opportunity to share is some of the recommendations. As a true community-based organization that's out there in the community trying to address barriers to care, funding that doesn't capture our services that are needed is a huge challenge. For example, resources for travel time to provide services out in the community, to be able to capture translation interpretation services, and other kinds of engagement that's really needed to address barriers to care that incorporate cultural beliefs and ways of healing. It's also really important, on top of all the great discussion about workforce development, supporting resources for providers out there to address vicarious trauma, burnout, and compassion fatigue. Thank you for this opportunity.
So I know we were supposed to technically end at 4, but for our federal colleagues who are able to stay a little bit longer, we'd like to just make sure we have some time to respond. And really quickly, I'm going to just highlight briefly some of the common themes that I saw. The need for greater data disaggregation, language access, language justice, as Victoria mentioned, clinical research, which also ties into the data piece, workforce development, the need to address discrimination and anti-AA and NHPI hate, and ensure there's more visibility and inclusion and belonging of our communities. Culturally relevant interventions that are micro-targeted to our specific diverse communities. Funding, capacity building was across the board a thing that was raised by all of you. And outreach just on ways that we can better get resources out into our diverse communities. I want to thank all of you for sharing your both your personal reflections, but also your recommendations to us. I think we have been taking copious notes, and we'll be sure that we can follow up. And I do want to make sure I can turn it over to some of my federal colleagues in the White House and in HHS for their reflections as well. I also really want to thank Ethan and Soha and all of our youth leaders who are here today. Just your stories, your advocacy are so inspiring, I want to say to me, but I'm sure to many of us in this room. And so thank you for using your voices and also your just the fact that you've been able to grow API Youth Rising so quickly in such a short amount of time, I think really speaks volumes to the power of the work that you are doing, but also gives us so much hope here in Washington, D.C. to see our youth so engaged. So with that, I'm going to turn it over to our SAMHSA colleagues for any reflections, and then please feel free to chime in for anyone else as well.
Thanks, Crystal. I want to thank all the community presenters. It's really critical that we understand and hear from you directly as we think about programs and policy. I think sometimes policy is empty without really the community voice. I think there are things that we can respond to. This idea of really looking at what works in communities and building a measurement data structure around that is something that we're trying to do. And I realize that we need to talk more with those of you, Sudarshan, you brought it up, to Vitana, you brought it up, Elaine. We fashioned a program and we're not sure if it's exactly working the way we think it should work. So I think we do need to do more co-creation of programs and policies, hearing directly from you. So we'll have to figure out how to pay you to get here and to talk with us too. I think, again, I want to reiterate what Crystal said about the young people coming and telling us their issues. It takes a lot of courage, I think, to do that. There are cultural divides in terms of where we come from, but also there's a developmental age divide too. And I don't know that we navigate that very well. So we need to look at you as leaders that are in the process of really developing what should be happening in behavioral health. And we don't hear enough. So I think we have to really think about how we can get you to become part of our advisory committees that are really the people that we listen to that come from the communities and outside of federal government. So I think this was very enlightening. We've spoken to a lot of you individually, but to hear you all in aggregate, we really have a lot of work to do. And I think we need to think about what is a broader plan for how we get input into what our policies and programs are. I know, for example, in some of the research institutes like the NIH's, they have field-initiated research projects. And I think we often think about what the community needs. We put out these grant programs, but maybe we need to really look at some field-initiated grant programs in our services administration too. So thanks very much again for taking the time to come here and speak with us. And we want to promise, and I know working with Crystal, that we will figure it out how we can be responsive to what you told us today, but not just today, last year too, and the months in between. We will be responsive. Thank you.
I will speak about data because that's what I do, but I was very excited to hear time after time after time the call for disaggregated data. And I think we can feel very happy. We cannot rest, of course, but we can feel very happy that Statistical Policy Directive 15, the revision that was released in March, and we have 5 years for federal data collections to transfer over to fully using those standards. It requires detailed data by default. So there are very few reasons why detailed data would not be collected, and that might be due to data security, issues possibly with re-identification of de-identified data based on very small communities, things like that. But by and large, data are to be disaggregated. And the requirement has checkboxes for 6 categories for each of the minimum categories. So that would be 6 categories under the Asian category and 6 categories under the Native Hawaiian Pacific Islander category, plus that write-in for individuals that do not identify with those 6 categories or identify with additional categories. It's important to remember this is a minimum. More categories can be used. This is the minimum standard. So pushing for additional categories that might be used would be a good thing to do, and pushing for the use of those data, that they be reported, that they be used properly, that as individuals who work with communities, that you collect those data in a responsible way, that you protect the privacy of individuals. I heard several people saying that individuals may be hesitant to provide detailed information, their name or their racial identification, because of stigma, because of danger, for other reasons. And so making sure that we protect those data properly and that we respect those data by using them. If we take people's time to collect their data, we have a responsibility then to use those data to make change. So Statistical Policy Directive, the revision, is a huge step, but it is one step. We have a lot of work to do across all of the minimum categories to make sure that this is the minimum, that we do more with this over time. But I'm glad to work in partnership with you all to understand the importance of good data collection and using those data. And I'm hopeful that we can move forward with HHS, with the other federal agencies as well, and then it trickles down to other organizations. But we will be pushing for this, and HHS will be putting forward opportunities for public comment. We are working now, since the Statistical Policy Directive was released very recently, we are working on exactly what those public comment opportunities will look like, but we are committed to having more public comment opportunities for how HHS, and then we will transfer this to other agencies, share those with other agencies, how we transition to really the spirit of this new standard. So I want to thank everyone for your comments today.
Really quickly, so for those of you who are not familiar with the White House Initiative, we'll make sure that we can follow up with additional information. But just given the topics you mentioned, I want you to know these are many of these issues, although we're talking about it in the context of mental health, they are long-standing issues that are cross-cutting for so many different areas, whether it's education, housing, healthcare. And so for the White House Initiative, we actually have a federal interagency working group comprised of 50 federal departments, agencies, and offices that help us to coordinate our whole of government response to advancing equity for our communities. And so as part of that, we actually have subgroups. Data disaggregation is one, language access is another, and then we also have an anti-Asian hate / belonging inclusion subgroup that is meant to address so many of the concerns that were raised, including the rise in anti-Asian hate over the pandemic, but also just longstanding discrimination against our communities that we know certainly impact the mental health and well-being of our communities. So I just wanted to share that because these are, like I said, we're not only dealing with those issues in mental health, we are seeing it across the board, regardless of the issue area, and it is something that our White House Initiative is very committed to addressing. So I wanted to just thank again all of you for your time, for being here, for sharing your stories, and for your recommendations as well. And as Lark mentioned, although this is just the second time that we are convening in person like this, please know that the work does not stop here. It has continued from the day after our summit last year, and it'll continue in the months and years ahead. So we are hoping that we can continue this collaboration and this partnership for those of you who are here physically in the room, but also for many who are tuning in virtually as well. So with that, thank you so much again. I'm going to turn it over to Kota.
Okay, we're almost there. We're almost out. I know we're all like really sore from sitting for like 2.5 hours. Look, I just wanted to take a step back. We've had some very substantive, serious conversations about policy, but I just want to take a step back and recognize how badass everyone is in this room. I mean, it's amazing to see not only the positions that we hold in our communities and in a variety of organizations, but just the dedication, the passion is so clear, and the momentum is so clear, and I think that's really exciting for all of us. So thank you all again so much for being here, taking the time to be with us. I just want to give a special thanks. Well, really quick too, I want to recognize and thank Crystal for mentioning the folks who are not in the room. I think that's really important, and I want to give a shout out and recognize all of those advocates across the country who are doing the work alongside us. Real quick thank yous. I just want to thank the White House Initiative on NHPIs for being such a great partner in this. Erica, you here, Swan, Deanna, and of course Crystal, Ka'ai. Thank you so much for your work. I want to thank SAMHSA for being here. Yeah. I want to thank the Domestic Policy Council for their support. I want to recognize my colleague Kushi, who has been running around in the background, taking care of a lot of logistics. And then finally, I just want to underscore the thank you to our young leaders who are here today. We're just so glad that you can make it. Your presence here is incredibly valuable, so thank you. Yes. Okay, with that, last thing. It didn't happen if there were no photos, right? So what I'd love to do, and I know some people need to catch flights. If you do, please don't miss the flight for this. Leave if you need to, but if you're able to stay for a group photo and you feel so comfortable, I think what we will do is move these tables. We'll move some of the microphones off, move the tables, have everyone come in the center, and would love to have the AAPI Youth Rising folks hold this lovely sign back here, and we can all take a group photo, thanks to Gabe in the front. With that, thank you all so much again for being here.